We shall now go on to our next speaker, Dr. Jatinder Singh, and he is going to talk to us on a very important talk, differentiating type 1 CNV and PCV.
So thank you, Dr. Chitra, for this opportunity. I'll be talking on how to differentiate, or whether do we need to differentiate BVN from a type 1 CNV. So PCV, even after 40 years after it was...
So sorry to interrupt, your voice is slightly feeble, if you can...
Yeah, I'm good. Yeah. Is it better now?
Yeah, much better.
So even after 40 years of its formal introduction by NUZ, the PCV disease as such still remains an enigma, and it is yet to be comprehended completely. There are certain unique features that help us to differentiate clinically and with imaging, but there is a clear-cut need to differentiate this from the neovascular AMD because of there are some similarities, but more because of its differences. Primarily, the natural evolution of the disease, the clinical heterogeneity, and the long-term prognosis of PCV significantly differs from the typical AMD. So why do we need to differentiate is not just based on its clinical features, but even the choice of therapy is sometimes different. We would prefer a particular anti-VEGF for PCV as compared to a typical AMD. And also if and when the PDT becomes available, the additional use of PDT can be disease changing in cases of PCV. The diagnosis of PCV typically depends on strong clinical suspicion. And then based on the OCT findings, we can come to a decent narrowing down of the diagnosis. Our ICG still remains the gold standard for the diagnosis of PCV because it picks up the polyp and the branching vascular network, which is the pathognomonic features of the PCV disease. So earlier days when ICG was not so good, people used to rely on FA, but in less than 10% cases, these polypodal related CNV membranes would be picked up as classic CNVMs. The rest of them would be labeled as occult CNVM. But with the advent of AI and its coupling with the FA, there is a report which suggests that around 85 to 90% of these PCV membranes can be accurately diagnosed based on deep learning network and the FFA. However, for the time being, ICG still remains the gold standard, but because of its limitation in the Z-axis primarily, and also because of its invasive nature, people have moved on to OCT-A to diagnose this entity. So there is a good agreement between the swept source OCT and ICGA, as has been shown by this paper. However, there are certain cases which may not be picked up on ICG because the polyps are either unambiguous or because the patients have been treated and they are not treatment naive. The treated eyes, the polyps might undergo regression, and when you want to later revisit the diagnosis, it may be a challenge to differentiate this PCV from a typical AMD. So what is type 1 ANV, which has been defined as a neovascular complex between RP and Brooks membrane. And this is very similar to what is the definition of BVN as proposed by many authors. So any neovascular network in the sub-RP component, in the sub-RP compartment, in eyes that have typical features of phenotypic features of PCV. So here now indirectly we have to pick up phenotypic features to call it as BVN, otherwise it should be labeled as type 1 CN. So vascular network is basically described in these three headings: the shape, the branching, and the morphology. And there is a study to suggest that the shape and the branching, or the numerous tiny capillaries, are predominantly seen in PCV. However, the p-value was barely significant in this. The characteristics of BVN on OCTA are basically three types: the trunk pattern, that is the type 1, which shows a main trunk and numerous vessels which radiate outwards towards the periphery. Type 2, which is the glomeruli pattern, which does not have a trunk, and the whole capillary network appears as a glomerulus. And the type 3, that is the stick pattern, where there is no identifiable feeding vessel, and there are fine vascular networks. So identifying these three patterns actually helps to differentiate and probably prognosticate these cases, especially when patients are treated with the combination therapy. So PCV is not just straight one type. There are now subtypes recognized. The type 1 PCV and the type 2. Type 2 is the what is typically described as typical PCV, which has no or faint BVN, but predominant polyps. The type 1 PCV is apparent BVN on ICG and is similar to AMD in certain parameters. It has larger lesion size, smaller polyps, sometimes which is not clearly seen. Choroidal thickening is lesser, no pachychoroid specifically associated with it. And the response to PDT and the prognosis is similar to AMD. So type 2, I think there is not much confusion. If you are able to see the polyp and if there is no feeder vessel, we would probably label it as type 2 PCV. So type 1 PCV, which is the polyps which are associated with neovascular AMD, as some have called them, is also called as the polypodal choroidal neovascularization. So these are the examples based on the schematic. You can see there is a feeder vessel. The feeder vessel is actually not breached the Brooks membrane and it's not come above the RPE. And till that time, it is type 1 PCV. So the membrane extends laterally in the sub-RPE component, in the sub-Brooks component. The type 2 PCV has now breached the Brooks membrane and is now laterally grows between the Brooks and the RPE. So these are the cases which have lateral growth, which is very limited. So you will not see much of a network. So these are the clinical pictures and the OCT pictures. You can see this network and the polypodal choroidal neovascularization, which shows the features as described. So whether polypodal choroidal neovascular membranes are just like another form of a phenotype of neovascular AMD, no, there are still differences. The AMD is seen in little elderly patients. There are racial predilections. The Asians show this PCNV more often. And the visual acuity is, though not as good as the typical PCV, is better than the neovascular AMD. In addition to that, the response to therapy, the benign course of the disease, the lack of drusen and slightly thicker choroid also help to differentiate PCNV from neovascular AMD. This has also been supported by clinical pathological evidence because of the immunohistochemistry and certain certain histological markers. It is suggestive that the PCV is a distinct disease from neovascular AMD. There's a recent paper on fractal analysis, which studies the vascular perfusion density, the fractal dimension, the lacunarity, and it has shown with binarization, just like ImageJ software. This is a fractalysis software, which has shown that the PCV and PCNV, the type 1 and type 2, there are certain differences. The type 1 CNV and PCNV have similar neovascular architecture and branching complexity. The PCNV is more heterogeneous than the type 1 CNV that's associated with neovascular AMD. But this may be also because of the shadowing artifact from the massive subretinal hemorrhages, which was associated in almost 1/3 of the cases. And PCV eyes also show higher vascular perfusion density as compared to the type 1 CNV. So in spite of the advances that OCTA seeing these years, I mean, there are still limitations, not primarily because of the machine itself, but inherent to the disease pathology. The large PEDs, the extramacular polyps with exudation, hemorrhage, the massive organized hemorrhage and exudation, and polyps with significant BVN can still cause confusion. You can see in this picture from the literature, you can see the neovascular network of AMD, which can be very similar to a PCV case and a case of CSE, which is again could be a precursor of PCV. So what should we call it? Should we call it as BVN? But the recent literature from the Asian Pacific has shown that it's better called as benign neovascular network rather than calling it as branching vascular network. The neovascular network observed in the same plane as type 1 CNV, that's between the RP and Brooks. The branching neovascular network or type 1 neovascularization then should be used as purely for descriptive purposes. And if there is a discussion specific to the cause, if it is associated with pachychoroid, in those cases, it can be probably labeled as pachychoroid neovasculopathy. So to conclude, the morphology of vascular network is not just affected by the disease per se, but is also affected by the activity and the chronicity of the disease. And without visualizing the polyps clearly, it still remains a challenge to confidently differentiate PCV from the type 1 CN on Octa. Thank you so much.
Very nice talk, Jatinder. Srinivas, do you have a question?
Yes, so Jatinder sir, very well, good talk. I would just like to know whether when they say that the signs of activity on Octa, like there is the branching dense capillary network, the presence of anastomose or loops, and perilesional hypointense halos. And are these pretty much similar? These biomarkers are pretty much similar in cases of PCV and CNV, or how do we look in for the biomarkers in either of these cases?
Frankly, I have not looked into that depth of looking for biomarkers. We've just looking as actually just for diagnostic purposes. Like my main interest was to differentiate a network. So just by looking at the network, can we actually differentiate PCV from AMD? And I have found that even the literature is divided and there is no clarity on a particular network being called as a BVN vis-a-vis type 1 CNV. So regarding your question, I have not actually looked into biomarkers. Maybe Jay or Ritesh can shed more light on this.
Jay or Pradeep or Divyansh, Ritesh sir, anybody? Yeah, Ritesh bhai, please go ahead.
Yeah, I have looked at these morphological networks only or purely on basis of whether to look at them as active or dead networks. Okay, so we look at those prune tree appearance and the loops and all, and the perilesional halos. Regarding comparing BVNs from PCV in terms of these morphological parameters, I don't think I have really looked into it. I still go by what Dr. Jatinder had put up in his last slide. If I identify a polyp, I pick it up as a PCV on Octa. Otherwise, it's practically very difficult to differentiate the two kind of networks.
Thank you.
Dr. Jay, quick comment and we can move on.
Nothing to add. I agree that it's almost impossible to differentiate unless you change the level of the segmentation. Then you may be able to see how they are located as per the differentiation what Dr. Jatinder explained.